All right, so today's speaker, Dr. Lisa Mitchell-Bennett, was born in Mexico City. Dr. Mitchell-Bennett's background in journalism and community organizing led her to the Rio Grande Valley to work with Central American refugees in the early 90s. With advanced degrees in public health and international development, she's worked in Peru and Central America and managed job training and adult education programs in Philadelphia for a time. She returned to Texas where she co-founded a binational community health worker project and managed school-based health centers. For 2 decades, she has led community engagement efforts at the University of Texas Houston School of Public Health in Brownsville, managing programs and partnerships that address non-medical drivers of health and health disparities with community health worker-led programs like Tu Salud Si Cuenta to prevent and control obesity-related chronic conditions. For many years, she authored a popular health column in local newspapers, and she co-facilitates a 22-year running collaborative action board dedicated to improving health equity in the Rio Grande Valley region. It was through the efforts of the CAB that the first farmers markets, community gardens, and urban farms were established in the Rio Grande Valley. Dr. Mitchell-Bennett is committed to an asset-based approach that values culture and historical context, centering the lived experiences of the people most impacted by programs, policies, and health conditions. Dr. Mitchell-Bennett has served as the president of the board of the Brownsville Wellness Coalition and serves on the board of Friendship of Women Incorporated. She is an ardent advocate for increasing community access to nature and green spaces. She loves her beautiful border community of Brownsville, where she and her husband have raised three amazing now grown-up kids. So without further ado, I'll turn it over to you, Dr. Mitchell-Bennett.
Thank you so much, Wesley, for that nice introduction. I appreciate it. Today, I'm going to be talking about the Rio Grande Valley and the region where I live and work, but also a couple of different topics. So I wanted to just kind of give you a brief overview of the session. First, I'm just going to review some challenges and assets and opportunities in the Rio Grande Valley and some examples of initiatives that are currently trying to address food insecurity as a social determinant and also strengthen the local food systems. And we talked with the food security work group folks who invited me that we also wanted to share some qualitative data from a study with non-US born individuals living with diabetes in mostly rural areas of the Rio Grande Valley to give voice and insight to their lived experiences. So some kind of, I'm going to start out with just sort of background that may be familiar to many of you if you're familiar with the region, but just to kind of give an overview, and then we'll go into that qualitative study. So some context and challenges here in the Rio Grande Valley. As you know, it's located on the US-Mexico border. It's home to three of the poorest metro areas in the United States, with its median annual income half that of projected for the rest of the state of Texas. It is a persistent poverty designated region. As you know, the rest of Texas is left with no Medicaid expansion, and in our area, that means that over 50% of adults have no health coverage or health insurance. So our physician to patient ratio is challenging, and we also don't have a public hospital for a region of over 1.4 million residents on the US side and many more on the Mexican side of the border. So some additional challenges in our population, approximately 80% of the adult population is overweight or obese. Nearly 1 in 3 adults have diagnosed diabetes, and many more are undiagnosed, although we are seeing a slight reduction in that over the last few years. Higher rates of cardiovascular disease, cancer, liver, kidney, and infectious diseases. We do have high rates of disability from chronic diseases, and we have the highest amputation rate in the nation. On the positive side, some protective factors in our region include strong family support. We have multi-generational households, multi-generational caregiving. We have very low crime rates, despite national narrative. We have very low rates of violence and crime. We have strong cultural pride and ties to our sister communities across the border. We are a bicultural community, predominantly Latine. We are also an agricultural region historically, although we're growing quickly. We have many natural resources, fertile ground, and weather that allows for long and multiple growing seasons. And I would say that scarce resources have really inspired some creative and collaborative efforts in our region. So I wanted to just kind of share some efforts to address food and nutrition insecurity in the Rio Grande Valley, since that was the committee that invited me. So I wanted to respond to some of their priorities. The Brownsville Wellness Coalition is one of those entities that has a mission of strengthening local food systems, improving access to nutritious and affordable food, educating the public to produce, cook, and eat healthy local food, and promoting food and financial sovereignty among its growers and small farmers. Brownsville Wellness Coalition envisions a future where all community members sustain a healthier way of life, and everyone will have the freedom and opportunity to be self-sufficient. So the programs that have been working hard over the last 18 years to achieve that mission is the largest and first farmers market in the Rio Grande Valley, which continues today and continues to grow. La Cocina Alegre, which is a healthy cooking curriculum, partnered with Sustainable Food Center out of Austin and adapted it culturally. And we have urban farms that are protecting and restoring vulnerable, undeveloped land, and community gardens teaching people how to grow their own food. We also have launched a mobile market that brings produce into more accessible to low-income neighborhoods. Another kind of exciting group that is relatively new, a couple of years old, is a pretty dynamic and visionary group that's composed of leaders from diverse industries in the Rio Grande Valley, and it's united by a common goal to cultivate a food system that fosters health, prosperity, and well-being for all. And this is sort of a 2 to 3 county initiative that has crafted a regional food charter. It co-hosts our regional food summit, and we work with the educational Region 11 and connecting growers to local farmers and to the school districts across our region for food service procurement. It's affiliated with the YouTube Rio Grande Valley Center for Sustainable Agriculture, the Hub of Prosperity Farms, and many other community-based partners and growers in the region. And one last just example of sort of a positive initiative around nutritious food security, nutrition security, is something that we're doing out of the School of Public Health here in Brownsville, serving large regional partnered diabetes prevention programs, and our campaign Tu Salud Si Cuenta, which spans about 8 or 9 communities across the region, to address obesity and promote healthy lifestyle change. And what we've added to those programs is a screening and component around nutritious food bags. We partner with our farmer and Brownsville Wellness Coalition to provide participants opportunities for actionable support to incorporate changes that they're learning about in their programs by providing them with seasonal produce, with recipes, and also to address nutrition insecurity. And we are going to be sharing these slides. And so there are some video testimonies from that initiative that I'd love for you all to watch. I don't think we have time today, but feel free to click on the link and watch folks sharing their stories and testimonies. So I wanted to kind of move into a new topic, and that's really sharing some perspectives from a larger study. And then eventually I'll get into the qualitative study where we can hear a little bit more about people's lived experience. So the broader study was focused on a non-US born immigrant population living in the Rio Grande Valley, participating in a diabetes intervention with several safety net clinics, federally qualified clinics, and other safety net clinics. These are folks with diagnosed type 2 diabetes, normally uncontrolled when they enter the program, majority of them without health insurance, low income, so lots of challenges. So there was a quantitative study or 2 quantitative studies that examined the association between very specific social determinants of health barriers and comorbidities of depression and hypertension among people living with type 2 diabetes. food insecurity, as well as urgent financial, social hardship, transportation barriers, insurance and healthcare barriers, major stress from lack of medical provider, and medical supplies were non-medical factors that kind of emerged from our documented questions and program services in a factor analysis that was conducted. So I'm going to shout out Dr. Sharma, our amazing leader here, who asked that I share the qualitative piece of the results from that body of research here with you all today. So this is not specifically focused on food insecurity, but may provide some perspectives of marginalized populations and factors that are influencing their experience of health and resilience. So I'm not going to go through this in detail, but I did want to point out, just to sort of describe the population that was part of the qualitative study, again, part of a larger study. They in the larger cohort, folks experienced 69.9% of the total sample, or the total participants, experienced at least 2 or more social determinant of health barriers, and only 8.4% of the total sample had 0 barriers. And these are folks that had the diagnosed diabetes, type 2 diabetes, and also the comorbidity of depression. When we looked at folks in the group or in the cohort that had type 2 diabetes and hypertension, overall 79.6% of this total sample experienced 2 or more barriers, social determinant of health barriers, and only 2.9% of the total sample had 0 barriers. So all of this to say that this population of low-income uninsured individuals living with type 2 diabetes and other chronic comorbidities experience multiple and complex social non-medical barriers. So probably not news to anyone, but I wanted to sort of clarify what people are going through in this population. And so now I'll move into sort of the main crux of this presentation, which is the qualitative piece that were conducted out of this population. And the study is titled La Cruz que Cargamos, a Sociocultural Perspective of Non-US Born Borderland Residents Living with Type 2 Diabetes. So the specific aims of this study were to better understand complex social and structural determinants, as well as protective and resilience factors related to chronic disease management among non-US born borderland residents. Also, another aim is to center the experiences of populations that are living with complex vulnerabilities and resiliency in the disease narratives in order to better represent their voices and realities in the scientific literature. And a third aim is to identify current social needs, barriers, coping mechanisms experienced by non-US born borderland residents in order to inform and improve design of assessment, intervention, and evaluation. So the methods for this study was an engaged critical phenomenological approach. We focused on understanding the meaning that people give to their lived experiences, embedded within a socioeconomic, cultural, and political context. We also explored participant sense-making and emotions related to topics, which we'll see as we start hearing some of the quotes. It was semi-structured, in-depth individual interviews. It was a purpose sampling. These participants were specifically recruited from this same diabetes management program in the previous study that I mentioned. And that was mostly because that was the population that we were interested in, but we also had some supports around that program, including social worker, case management, and community health workers. So as we were doing these in-depth interviews, we knew that if there was some trauma or there were some needs that were identified, we had kind of a support structure around that. The interviews were recorded, transcribed, and analyzed in Spanish. And there were also demographic questions administered at the time, as well as an adverse early childhood experience, or ACE, immigration questions, and social determinants short screener. So the inclusion criteria for the qualitative in-depth interviews were current or past participant of this diabetes program that I mentioned, could be male or female, 18 to 75 years old. We did ask that they be born out, having been born outside of the US. So we're looking at a population that immigrated after the age of 16. So they immigrated as adults or close to adults. And they had a Spanish language preference, which would indicate less US acculturation. And they currently had to reside in the Rio Grande Valley in either Cameron or Hidalgo counties. So the topics, again, you know, these were semi-structured, but the topics that we wanted to address were just life in the borderlands, health and lifestyle behaviors, nutrition, food access, physical activity, stress management, disease management, coping mechanisms, resilience factors. So we really wanted to not just learn about the challenges, but also how do people cope and you know, what strategies do they use? Again, additional topics were also explored in these interviews, and they will be summarized in future study, but this is what I chose to share today. And again, a little bit more about the approach. If you're interested, I can give you more details about this, but so I did try to really document my own researcher biases and acknowledge those in the role of the interpretation of the data. I achieved immersion of the recordings and transcripts in their original language, took exploratory notes on each interview transcript and developed some codes, and then brought in a second reviewer from the region, from the culture, to read through transcripts and identify codes and code families. We discussed and achieved consensus on the codes and the code families and themes, compiled a table of experiential themes, and tried to identify commonalities and validate or invalidate some of our themes. Yeah, so looked for connections, looked for phenomena and meaning, went back to the literature to see how the phenomena might align with the literature, and I, of course, identified representative quotes, and I've pulled a few of those to share with you today. So here are some of the results. Just some demographics around the individuals. You know, 40% of them had 8th grade or less education. All of them had come to the US after the age of 16. All of them, primary language was Spanish, so they did fit the criteria. So some additional context just to kind of give you the picture of where people are living and kind of what the interview settings were like. So these were mostly folks living in semi-rural, many of them colonia settings, in trailers, mobile homes, kind of alternative housing situations, rooms added on to garages and sheds. Most of them lived with at least one extended family member, often their grown children or other relatives, nieces, nephews. Several appeared to be underhoused or experienced some housing insecurity, as they indicated that they move often, they go to different family members, and they have to move because they can't, you know, because of economic barriers. But not one of them mentioned housing as a challenge when we were talking through. So it was very interesting. Half of the interviews were conducted out of doors due to the lack of space or privacy inside homes. And often interviews were interrupted by dogs, roosters, caregiving needs for young children, elderly, disabled family members, which really provided some insight into the rich and complex lives of participants and their families. So what came out of those interviews were, and I decided to focus on factors that impacted the participants' experience of illness and also factors that impacted their resilience. And so I'll go through each of these. So the factors that influence experiences of illness, the themes that we came up with were stress makes me sick and sustos. So stress was a major driver of it emerged as a phenomenon, as a major driver of illness identified by the participants. They emphasized the connection between stress and health and their own diabetes management. They emphasized this impact of stress more so than really other lifestyle, behavioral, or even hereditary factors. So they seem to feel like stress was the major driver of their diabetes. They also, sense making about diabetes included a belief that it was caused in many cases by the high stress of trauma, of either one trauma, multiple traumas, or what in Spanish we call susto, or kind of a fright or fright-induced sickness or illness. Stressors also were mentioned that included financial ability to access healthy food. So housing insecurity, although wasn't named, came out in their need to move often. Fear due to immigration status or family member status, transportation and other family relationship challenges, as well as isolation. So here's just a sample quote from the first phenomena about stress makes me sick. And this is translated from Spanish to English. Sometimes we want to do what is healthy, what is correct, but we can't. At the clinic, they say to eat healthier food, take your diabetes medication, walk every day. I can't afford the food, I can't afford the medication, and I'm afraid to walk outside because of the dogs, and now worse since the new government. I'm afraid of being picked up by the migra and having to leave my kids. I told the doctor, how can I be healthy when I'm afraid to go outside? And that was a female 40 years old. Another example of the stress makes me sick and sustos. This is a longer quote from a woman 58 years old. He was very violent. He was very angry, but he has always been very violent, very aggressive, and that also causes me a lot of stress. Yes, it also affects my sugar and health. I feel like I got it from susto because my parents didn't have diabetes. I worry about my son. I tell my mom that I feel like he absorbs a lot of stress from the conflict with my husband. My son is very sensitive. He keeps everything inside, and right now he is depressed. He's eating more again and he is gaining weight. He needs to let it out, maybe with a counselor. It helped me. As I would always say, we walk on pieces of glass because of my husband. Right now he's in jail and I feel more peace. And my son tried to protect me when he was growing up. It's too much stress for everyone. I got diabetes from it and I don't want the same to happen to him. And then another gentleman, 63 years old, with a briefer quote, says, if I can't stay calm, I won't ever be healthy. If I don't learn to control my emotions and find ways to relax, the stress will kill me. You know, stress can kill you. So you can see sort of how that theme came out around the factors influencing experiences of illness. And so I wanted to also share some factors influencing resilience. So the first is the coping mechanism of desahogar in Spanish. An expression was used by participants in various contexts to describe the act of releasing emotional tension, expressing feelings, or finding relief from psychological or emotional pressure. Participants directly connected desahogar to the practice of stress management and improved health and diabetes control. So the noun un desahogo, or the unburdening, is the closest English translation that I can find, was also used with a sense of emotional catharsis or emotional purging that was considered beneficial to their physical and mental health. The participants discussed that they were able to process past traumas and post-traumatic stress disorder and manage anxiety and depression through counseling and talking with trusted friends and family members. There was not the expected stigma about talk therapy or behavioral health intervention, and in fact, several of the participants had received therapy at their clinic and had had positive experience. Again, these are folks who are currently or previously in a diabetes intervention, so they obviously had access to some of these resources and referrals. So just an example, a quote from a 58-year-old woman, another 58-year-old woman. the promotoras or the community health workers listen to you. They give you time, and it really helps me to vent. It helps a lot to control my sugar. Even just talking with you right now helps me relax. Unburdening or desahogando, I feel reborn after I share my emotions and get them out. I'm always so worried about others, feeling afraid about the current situation, the government, the fear that I don't take care of myself, and getting it out helps me control my emotions. So another just example of the participants' understanding of their need to unburden and their perceived benefit of sharing their struggles. So another coping mechanism is somewhat related to religion and faith, although a little bit of a different take than what I found in the literature. This phenomenon we called God gives strength to cargar la cruz, or carry the cross or bear the cross. It was used as a metaphor for stressors, challenges, burdens, and trauma experienced by participants. Participants' sense-making about their faith seemed to shift the locus of control over how to overcome and survive the burdens to the individual, to themselves. In other words, there was more of an active sense of control than the traditional definitions of fatalism in the literature, which are really more focused on kind of acceptance of the inevitable, predetermined, kind of submissive outlook about struggles or bad things happening. So according to participants, having a faith or a relationship with a higher power supported their ability to cope with difficulties in life and empowered them to take charge of overcoming these challenges. So it was a much more active and less passive perspective. Here's a quote to demonstrate this from a 52-year-old female. "It's not so much religion, but a personal faith in God. He's with us wherever you seek him, and you don't need to go to church for everyone to see you or something. And no, I don't go to just please people, but I do know the faith. I know God always gives me comfort and guides me to make decisions and do the work that will help me overcome the struggles, the depression, the high sugar. I may not have a piece of bread left to eat, but somehow God gives me strength to carry my cross. It's my cross to bear." So a final phenomena that we discovered was borderland culture, language, and proximity to Mexico as factors impacting resilience. And this is something that I'm really trying to explore in subsequent interviews. And here is just an example of that potential of actually borderland with all of its challenges and struggles, that the kind of homogenous culture or the biculturalism, it could actually be a protective factor. So a gentleman, 73 years old, said, referring to the Rio Grande Valley, "Well, it's full of Hispanics. Here in the valley, it's very common for people to speak Spanish. One doesn't even have to learn English. It's common for non-Hispanics to have interactions with Hispanics, and they're already used to it. They already know that we are very friendly. The food is familiar, that my house is your house, and 99% of the border people are Hispanic. Good people. Here in the valley, we like it a lot because one of the reasons we came here was for my daughter, and the other is that for my wife, who can travel because she has her papers. It's closer to go on a bus from here to Guadalajara, Mexico to see her family, and much cheaper. I say the culture, the food, the mother tongue makes us more comfortable." So that's just kind of one example of among many quotes of individuals saying that while on one hand there may be fear in terms of their family's mixed status or their status, there's also a certain level of comfort with the culture. And so we're back to this little graphic of the factors impacting experiences of illness. So the beliefs about diabetes and health, that stress makes me sick, that the cause has to do with the susto, or the fear and trauma and stress. And then the coping mechanisms of desahogar, or the belief that and the experience that unburdening or sharing or talking with folks about your experiences or your trauma can actually help you manage your disease better. And then also that sort of strength given by a higher power to not only just accept challenges, but also to actually take action and be able to survive and thrive. So kind of in summary, stress and coping among Latina immigrants is currently understudied. And so this is important, I think, particularly the resilience factors. Although scholars are increasingly interested in sociocultural factor influences on stress. Diabetes self-management studies often identify stress management as a behavior that's key to successful diabetes control, but don't necessarily provide insight into effective stress management strategies that are tailored to diverse populations. Participants were asked to discuss their health and well-being, their diabetes, but instead the narratives really leaned away from disease state or specific measures to control, and centered on stories of family, past trauma, and the impact of stressors on their health. Participants also emphasized stress rather than lifestyle change or even medical treatment as having the most impact on their health in type 2 diabetes. Participants also acknowledged the role that stress plays in diabetes management and emphasized that counseling, therapy, and the practice of desahogar, sharing or unburdening past trauma, help them better manage their mental and physical health. And the expected stigma about counseling or behavioral health treatment did not emerge in the narratives among this small population. Opportunities for peer desahogar or unburdening, relaxation, meditation exercises, and counseling should be considered as strategies in type 2 diabetes management and other health interventions specifically in this population. And while a belief in God was consistently mentioned across participants in the study, emotion and sense-making about prayer and faith emerged as a more active coping mechanism rather than a passive fatalism or relinquish of control, as I've found in the literature and is often found in other studies. So this aligns really less with fatalism and more with religious social capital, protective assets that might mitigate stress among Latina immigrants. I also found that acculturative stress arises for immigrants with the demands required for adaptation to a new culture. And when they're not addressed, they can manifest in behavioral health disorders such as anxiety and depression. And potentially the unique borderland culture may require less US acculturation for individuals coming specifically from Mexico, because it is more similar to their homeland language, culture traits, predominant Latina ethnicity of its population. So this may reduce acculturative stress experienced in other regions, something to explore. However, experiences of discrimination should also be further explored as a cause of stress in this population, because there was some mention of discrimination. The recurring themes of stress and trauma impact on health were closely tied to the conversations about the challenges of living in the borderlands with mixed or no immigration status, which will be further explored in subsequent papers. So just some strengths and limitations of this small qualitative study is, the strengths is that it's focused on health disparities and resiliency, not just challenges. I believe that it contributes to a gap in the literature, and it can guide assessment and intervention development for similar populations. Limitations are, of course, that it was not a random sample. There's some selection bias. They came from a program, sample size very small, and it was a point in time, not longitudinal study. So just the overall conclusion is that we found significant association of urgent and financial and social needs in the larger study. Housing insecurity, underemployment, and family crisis with depression, and identified opportunities to further explore social determinants of health associations with hypertension. And in all the studies of the larger body of work, the majority of participants experienced multiple social determinant barriers and exposed an increased risk for poor health outcomes. Understanding the specific social determinant factors that increase the odds of having depression and type 2 diabetes, as well as hypertension and type 2 diabetes, can provide guidance for risk assessment and prioritization for intervention designed to prevent and improve both conditions. So the qualitative study shared the lived experiences of individuals seldom included in the mainstream narrative, providing insight to further research and similar populations. Using this phenomenological method that really originated from the desire to explore and understand the experiences, emotions, and sense-making around beliefs about health, coping, and resilience. The phenomena of stress makes me sick, susto, God gives me strength, and desahogar emerged. Borderland culture, language, and proximity to Mexico emerged as a factor impacting resilience and needs further exploration. So just as in summary, I think, and just for future study, a decolonized approach and intersectionality theory guided these studies from conception and formation of research questions to the literature review, researcher bias, self-reflection, interactions and discussions with participant populations and community health workers, and analysis and conclusions. This will continue to ensure that these results are shared with the participant population to create discourse in a borderland context in order to apply learning to improve equity and address health disparities related to living with type 2 diabetes. So my references, there are many. And I do want to thank the Salud y Vida Diabetes and Intervention team of community health workers and social workers, and specifically Vanessa Saldana, who helped code the transcripts. Of course, amazing Dr. Reiniger, Dr. Lee, Dr. McCurdy, Dr. Sharma, and very importantly, the participants who shared their stories and allowed me into their homes and lives, and the many borderland residents who have touched my life, enriched my community, and informed my learning for over 30 years that I've lived and worked in the Texas-Mexico borderlands. Thank you. Stop sharing.
Great. Thank you so much. Felicia, I'll turn over you to start the Q&A and I can look at the chat.
Sure. Hello, everyone. Thank you, Dr. Bennett, so much for your presentation and just the wonderful layout of your work, as well as the context and the health conditions of the surrounding area. So thank you so much for sharing. I do want to open up the floor for questions. Feel free, if anyone has questions that you'd like to ask Dr. Bennett, please feel free to put them into the chat, and we will bring them up for discussion. There was one comment by Rosalia that says that this was an interesting observation about housing vulnerability, or that she maybe encountered about housing vulnerability. She was involved in a survey involving immigrant day laborers who reported they had never experienced discrimination, but then went back and asked about the specific discriminatory actions. For example, denied services at restaurants, corner stores, and almost all had said they'd suffered from discrimination constantly. So I wonder if is there things like that came up when you were undergoing your questioning and surveys and analysis of where, like, when you asked one question, maybe there was a no, but then you reframed it in a different way and you found that it uncovered more
Yeah,
information.
absolutely. And hi, Rosalia. Good to see you. Yeah, that's an excellent point. And, it also matters who's interviewing, and, no matter, who's interviewing, what the context is, and, how the participant was recruited and all of that. So for sure, I do think like these interviews often lasted, 2 hours, and then I had to go back and I'm pretty familiar, like having worked with this population, but I still think, of course, things can be misinterpreted. I also think it's kind of like people, their reality is what it is, and they have kind of a hierarchy of needs. And I think if they don't feel like that's their biggest need, or maybe they were really focused on having the opportunity to talk about different stressors. Maybe they're used to thinking or talking about, housing because it's just like a day-to-day thing that they do. But this was more of an opportunity to talk about their past and their, we did some journey mapping, and I think it was able to trigger some conversations around stress and general stress. Like, you know, it's like all of the things, it's not one thing. So it's not just enough money. It's not just the medical condition. It's not just the fear of law enforcement, or, you know, it's all of the things. And so the fact that housing maybe didn't pop to the top for them doesn't mean it's not still a need. And Rosalia, I think it's a super good point. Like, you know, always going back and asking again and having different people ask and just listening, right? Listening for longer.
Thank you. There was another question from Kalia, who's curious about whether a stipend or incentive were provided for study participants.
Absolutely. And I'm sorry, I just didn't want to put too many of the methods slides up because didn't feel like this was an academic presentation, but yes, they were given $50 stipends, which in our area is actually, I kind of lobbied for a higher stipend. Usually it's still 25, unfortunately. But yeah, they were, that was a lot of their time. And also they were able to be connected to the social worker who, you know, in many cases, you know, provided them with a, you know, nutritious food bag. And so they had some support services that were added. But yeah, they were given a stipend or an incentive, sorry.
Awesome.
The journey mapping, yeah, I see Heidi McPherson's, yeah, they have not been published, and actually none of this has been published yet. So just FYI. But definitely am trying to do more interviews, and also there's so much, you know, so much rich information that came out of it. So that is definitely part of the plan. Yeah.
And then also Shrila asked about how your work is evolving in this current landscape.
Well, kind of my other hat is as a project manager here running the community interventions. You know, that's pretty much sucking up all of our energy and oxygen right now, just trying to keep things funded and keep the programs going. So I would say, you know, we're definitely seeing fear in terms of participation among this population, but we're also seeing with the community health workers, you know, going into the home, it does allow us to still be able to both provide services, information, coaching, and have learn from our participants, as we always do. So I don't think it's changed. It's more about where we're able to focus our energy right now, which is really just keeping things going. So that sort of a backing off of doing some of the qualitative work, unfortunately.
Yeah. Okay, and then we have another question by Libani, who says that they offer DWI classes, and the in-person classes were primarily attended by Hispanic participants, and they have seen a reduction in the amount of participants or the attendance, and have shifted to online classes, offering classes. And so I guess that kind of begs the question of like, are there ways in which you guys have adapted since, you know, with
sure.
everything kind of changing and the landscape changing? What are some of the adaptations that you've seen maybe around or within the work that you do to help keep folks engaged?
Yeah, definitely. I mean, fortunately, we had some practice with COVID. So we're kind of reverting back to doing online groups and classes, although there's a good note. Some of this, particularly this population, struggles with that. Either they don't have access to internet, or they don't have a smartphone, or they're sometimes even our phone service doesn't work when we're there doing visits. And so we do have some challenges. That's not everyone. That's probably not the majority of the population, but this particularly marginalized population that I did the interviews with, that is a concern. So we are still Fortunately, in this area, we haven't experienced people not allowing the home visits with a trusted community health worker or someone, a program that they're familiar with. So we just have to go to them, which is, actually better because it helps them. They have enough going on, like it provides them. But definitely like our sort of more community-based like classes and programming, we've had to move some of them online for sure. And we also use text messaging to reach people and send links to resources and videos and motivational things.
And some of the work that you've done, and this is just a follow-up question to that. What are some of the best, have you guys found that there are any kind of like best practices, and I don't mean to just kind of frame it that way, but to building trust with folks? Because a lot of people, you mentioned, didn't even want to go, were afraid to go out their house, things like that. So what are some things that you guys tried that worked to help, build that relationship?
I mean, I'm definitely biased because I've been working with community health workers for so long, but I just think people who have shared some of their experiences, who look like them, who sound like them, who understand them, who come from, not that, who are just from the same community and are well trained to understand how to navigate and connect with people. And I believe that our community health workers are that. I don't know that all community health workers are, but I definitely feel like our team is just amazing. And like, I couldn't have, part of the reason that I got such good response and was able to have these in-depth, vulnerable conversations with people is because I was trusted, because I was connected to the community health workers who have been doing work for so long. So no fault of mine. It was just, I was able to kind of be on their backs, I guess. And so I really do believe in that, like kind of go to where people are approach with someone who is very trustworthy.
Okay,
I don't know if that answered your question.
Yeah, I think so. And then I just want to make sure we have some more questions coming in. There's a question about when the study was conducted.
Oh, sorry. Yeah, I'm sorry. I kind of tried to take out some slides because it was so long and I probably removed some important ones, but it was actually it was 2024, fall of 2024. And some of the last interviews were into January, February of 2025. So you kind of know what big event happened during that time. And that's why there was a lot of reference to government, the new government and fear. Although I would say that's a theme for us and always has been, because we are a very, we do have a lot of law enforcement and always have. So this is nothing new for our community. But I think it was that moment where people didn't know what was going to happen. And so that was the fear of like, what's coming?
Yeah. Mm-hmm. And then
thank you for asking about the time frame. I'm so sorry I didn't mention that.
And then there's another question that is about how will this information be provided back to the community in a way that will resonate with them?
Super important question. And we actually have started doing that already. We have a plan to continue doing that. We have what we call PAL groups. They're what does it stand for? Patient Advocacy Leaderboard groups. And so the participants in this particular program, we invite them to provide us with ongoing feedback. It's part of our quality improvement process. And so I was already able to give the feedback to that group. It's a select number of people from that program. I've presented to our community health workers and to our regional community health worker groups. And so those are the three things I've done so far. And we definitely are working, because I want to continue analyzing some of this data and also conducting more interviews. I haven't done more than that. But I definitely am always sharing with the community health workers, and they also give feedback, and it helps to shape our programs and intervention. So just, I think, listening to the people who are working frontline with the individuals that are part of the population that we're serving, and then also directly with the people receiving the services is always super important. Good question.
Yeah, so thankful for community health workers, if there are any on the call. Thank you guys. And then we'll round out this time with, there's a question from Rosalia. So if you want to come off mute, Rosalia, and ask your question.
Great, thank you. And just really quickly, Lisa, thank you. You really took me down memory lane, like 10 years in Laredo. But I want to bring it to, you know, how does this speak to other diaspora around the United States, especially during this time? You know, I hear a lot about, you know, feeling more comfortable on the border, which is true. You know, it's closer to the culture, but at the same time, they're trapped by that double border, you know, the border to the south and the 26-mile marker to the north. So not only are they cut off from family in Mexico and in other countries, but they're also cut off from family and communities inland into the United States. So did you ever get a sense from them, you know, kind of like, for lack of a better way of putting it, who had it worse or who has it
Rosalia,
worse?
yeah, like you totally hit on a whole theme of the whole other section that I just couldn't, you know, fit for this first round. But it's a feeling of being trapped, and people who've like been trapped for, you know, 20, 30, 40 years, have never been able to leave this region, and like different reactions to that really came through. And then frustration that some of their kids can't leave, like even though they came as babies. And you know, they're doing well in school, they're getting offered scholarships, but they literally can't get past the checkpoint. And so there, you know, opportunities to go to a science fair in Austin or something, they've got to say no. So that level, the frustration of the parents and some of the folks that I interviewed is high. And that definitely, that feeling of being trapped came out as a theme. Just even though there's comfort here, and you know, but it's also, this is it, like for the rest, that's how people feel for the rest of their lives. This is it. This is where they are. Yeah.
Okay. Thank you. Thank you.
Thanks for bringing that up.
Hey, thank you so much for everyone for your questions and engaging. And thank you, Dr. Bennett, again for your presentation and for coming on and sharing your work with us. I do want to introduce myself again. My name is Felicia Coleman, and I, along with Jasmine Lehner, co-lead the learning session group that's kind of ingrained into the food security work group within the Health Equity Collective. We would love to hear from you. There is a survey in the chat that's linked, and then will also go out via email. So we do ask that you participate in that, and we'd love to hear from you. The food security group work group comes together each fourth Friday of the month. So we also encourage you to attend there. And also we'd love to hear from you in terms of what you'd like to hear in future learning series. So we thank you for coming out. We thank you for participating and just coming out to learn and collaborate with us. So with that being said, wish you all a great day and hope you all enjoyed your lunch, or maybe the lunch that will come after, and have a great day.
Thank you all so much for your attention and great questions. I appreciate it.
Thank you.